Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
So, Pat, before we start, I just want to say thank you for tuning into this podcast and apologies if it's not up to our usual sound quality. Our studio boss is away for this month and we want to keep giving you weekly podcasts. So
We're not in the studio.
So, yes, thank you for your understanding. Well, welcome everyone. Guess what we've got today?
Q&A!
Q&A. And I think it's quite an international Q&A today.
How terrific is that? I think it's great. I've listened to them already and it really pleases me when we hear from people all around the world. It's brilliant.
Yep, great. And obviously, are we going to do some chit-chat, Pat, or get straight into it?
We're getting straight into it.
I love it. Can I just tell people though that at home, Pat really doesn't stop talking. There's a lot of chit chat and we have very, very long conversations.
Podcast is all business.
I remember one time I said to Pat, don't you talk all day? Why must you come home and talk again? It was like the opposite, where women need whatever it is, words in a day, and the male needs whatever it is. I think we're the opposite. Anyway, I've put all my words into that one sentence, so let's get on to it.
You're out of words. Let's go.
Okay, let's go. All right, here's our first caller, Pat.
Hi, Dr. Pat and Brigid. My name is Megan. I've been listening to the show for a while and was excited to become pregnant this year. I'm now 22 weeks along. My question is about navigating Graves' disease during pregnancy, particularly the antibodies during pregnancy with Graves' disease. I had a thyroid ablation with radioactive ablation about 5 years ago, and since then have just been on a synthetic levothyroxine thyroid medication. Things were pretty under control, but over the last month, my doctor had me test my thyroid autoantibodies and found that the levels were elevated above the level of what could potentially cross the placenta and affect the baby. I saw the test results and felt very worried, made the mistake of doing some Dr. Google, and have just been having trouble because I have another month until I have an OB appointment. My endocrinologist just let me know they would continue monitoring it, but I guess my question is just, to what extent should I be worried? Is there anything that I can do in the meantime to affect those, the level of antibodies that might cross the placenta? And is there anything else I should be considering right now? Thank you so much for everything, all the great information. Thanks.
Wow. Gosh. So Graves' disease, Patty, what is that?
Well, Graves' disease is really quite a common thyroid disorder, and it has this peak incidence in women in the often in the pre-pregnancy years, sort of early 20s. So it's highly relevant to pregnancy care and something that we deal with several times a year. So let's go back to what happened with Megan before she was pregnant. It sounds like she's developed Graves' disease at some point in the past. Her immune system was making some of these thyroid receptor antibodies, and she was probably at some point in the past clinically hyperthyroid. So she may have presented with a tremor or something like that. And then she was diagnosed. She had quite a common and standard treatment, which is radioactive iodine, which is put into your body. The thyroid gland preferentially takes up that iodine, and the radioactive part will ablate or destroy the thyroid tissue, and so you can't make that extra thyroid hormone anymore, and your levels then go quite low, but they can easily be replaced by a little bit of thyroid hormone, titrated to get your levels back to normal, and then you're fine. What it doesn't do is stop those abnormal thyroid stimulating antibodies from being produced, and in a later pregnancy they can cross the placenta even if the mother by this stage has a well-controlled thyroid system. And that can be very relevant, obviously, to causing a similar form of hyperthyroidism in the newborn if it's not checked out. So do we need to worry? Not really, now we know what's going on. So we've got someone with a history of thyroid disease who has been wisely checked for antibodies in her pregnancy. They're found to be there. And all we need to do now is just to monitor the amount of those antibodies that are present throughout the pregnancy, and then alert the paediatricians that we could have a baby with a question mark over the baby's thyroid function when the baby comes out.
And is that a long-term issue that a baby might have?
Well, not really, because those stimulating antibodies will wear off. So they may need to monitor the baby for weeks and months, but we would expect normality after that. Okay,
so for this caller, Megan, what should she do now? Like, she hasn't got an OB appointment for another month, but it sounds like she's got an endocrinologist on tap.
So I'm going to have to interrupt here.
Right.
You said Megan. That's how we say it.
Yeah.
The American says Megan.
I thought I did say Megan.
I heard Megan. It's Megan.
Sorry, Megan.
In Australia, we say Megan. It's, you know.
We've got to get that right.
So, Megan, what can you do about it? Yeah, not really anything. There is some evidence that if your thyroid control is as good as possible during the pregnancy, which just seems like a good idea on face value anyway, then that may alter the amount of thyroid receptor antibodies that are produced in your favour and in the baby's favour. But really it's about saying, well, those antibodies are there, we can't really undo that, but what we can do is watch the baby very closely. And then when the baby comes out, first test we can do on the baby is from the cord blood, because that's the fetal blood. And we can look for the amount of antibodies and the amount of and the quality of the thyroid function in that blood, and then maybe take some serial bloods from the babies under the direction of the paediatricians over the coming weeks and possibly months. And in the rare situation where the transplacental passage of antibodies is enough to make the baby actually hyperthyroid, then they would manage that.
Yeah, right.
Yeah.
So for listeners that are wondering, well, what does the thyroid do, or why is it important in pregnancy? We've actually done an episode on thyroid in pregnancy, and we'll put that link in the show notes. Go back and have a little listen, because it's pretty vital, the function that it plays, and yeah, there's other things like post-thyroiditis. Is that how you say it?
Postpartum thyroiditis.
Yeah.
So
which
we're
comes
always
as a bit of a surprise to people too.
on the lookout for that as well. A flare after the baby comes in the various thyroid conditions.
Yep.
But this is one of those things that has been really very, very cleverly worked out over the years, how to effectively manage this to the benefit of mother and baby. And so I think the only person that we would be unable to help was somebody whose thyroid disease hadn't been previously diagnosed, or somebody who had known thyroid disease and for whatever reason the antibodies weren't being tested during the pregnancy.
Good. All right. Well, thanks, Megan. I said it right, I think. Thanks for calling in.
Hi, Dr. Pat and Brigid. First, I just wanted to say how much I appreciate your podcast. I've actually been listening to you throughout all 3 of my pregnancies. I'm currently 21 weeks pregnant with our third, tuning in from the Midwest United States. Your episodes have been such a helpful and comforting resource for me over the years, and so grateful for all of the insights that you share. I do have a question I was hoping you could maybe help with or give some insight on. My first 2 pregnancies with my daughters were essentially textbook through and through. This baby, however, on our 20-week ultrasound last week, we found out that I have a low-lying placenta with multiple small placental lakes, they're called. So just really curious on your thoughts. As of right now, I've been put on pelvic rest, limited exercise, lifting restriction. So this is all very, very new to me. As I said, my other 2 pregnancies were extremely textbook. So really just curious to know your thoughts, the types of complications and things that I may be facing going forward. All I know as of right now is that there's going to be a lot of ultrasounds in my future. And they're really watching me closely, which I'm not used to. So any thoughts you may have would be great. Thanks so much. And it truly makes a difference what you guys are doing. So I appreciate you.
Oh, lovely. What a lovely accent also.
Beautiful.
Beautiful.
And such a well-spoken description of the problem.
Yeah. Can I ask, did she say placental leaks or lakes?
Lakes.
Oh, God, I've never heard of lakes.
So, placental lakes are, if we look at the placenta on an ultrasound, there's lots of blood vessels, basically made up of blood vessels, isn't it, to transfer oxygen and nutrients through from maternal to fetal circulation. And occasionally there's these dilated areas where there's pools, bigger than average pools of maternal blood, and they're called placental lakes. They kind of look like a black blob on the ultrasound, and someone called them lakes. It's a bit of an unofficial term, but it refers to a placental appearance. It's slightly unusual. Is it abnormal? Well, we don't know. There's a possibility that the presence of lakes on ultrasound might be associated with a few increased, pregnancy complications like growth restriction. And it might be that if there's enough of those lakes, then the placenta isn't working as efficiently as it could be. Same thing as if the placenta was too small or heavily calcified. So when they're in the presence of those lakes, we tend to do some extra growth scans to make sure that the placenta just looks unusual but is otherwise functioning normally, or is there some associated growth restriction? And the same thing actually applies to the other issue, which is that in this pregnancy, for the caller, the placenta is sitting too low. Now, we know most of these will fix themselves, but so if we talk about fixing themselves, 20-week ultrasound, the placenta might appear to sit very low, but we know that a lot of those will effectively move up as the bit of the uterus between the placenta and the cervix grows, and that has the effect of effectively moving the placenta up and out of the way. And so we would typically rescan that woman after 30 weeks to make sure that was happening. When there's a low-lying placenta, that can also be associated in the statistics with a degree of growth restriction as well. And if we look at full-on placenta previa, where the placenta is covering the cervix completely, that's not only a challenge for the delivery of that baby. Okay, now there's no way up for the baby to do a section, but there's also an association with growth restriction. So exactly when we do that section might be affected by how well the baby's going.
Yeah, right. So she's right in saying that she'll be having a lot more scans.
Yeah, because there's lakes and low-lying. And the lakes might turn out to be nothing, and the low-lying might turn out to be nothing. And when she's rescanned after 30 weeks, the lakes will still be there, but they may be not affecting the fetal growth, and the position might have corrected.
Oh, best case scenario.
Yeah.
Oh, that's what we're rooting for.
Absolutely, but if there's no, even if there is a problem detected in terms of the fetal growth, this can be managed. So there would be an increased amount of surveillance, and ultimately, right up towards term, there might come a point where that baby was better off out than in, in terms of how well it was growing, and that would be a induction or caesarean section situation. I guess, again, the only thing that we could do wrong here is not know about it in the first place.
Yeah.
It's one of the many reasons why second trimester scanning is a good idea.
Yeah, how great that she found that out. Now, I just want to ask about the lakes. Does that make it more bleedy?
I don't think it makes it more bleedy. I think there are just some circumstances where it can alter the transmission of oxygen and nutrient from mother to baby.
Great. All right, well, best of luck. Let's hope. It's a bit of, it's hard, isn't it, if you've had 2 textbook pregnancies and birth, and then all of a sudden you're having your third and you feel like it's you're under more surveillance. Every pregnancy, a little bit different.
Different, and I think that surveillance is probably all that needs to happen here.
Yeah. Good.
Struggling with the anxiety that comes with adulting?
Or maybe you've suddenly become the parent to your parents.
Wondering if you might have ADHD, but unsure if or how to get a diagnosis?
I'm clinical psychologist Dr. Anastasia Horonis.
And I'm Ashani Dante. We're your hosts of But Are You Happy?
Bringing you all the self-development and mental health information you actually need.
New episodes drop every Saturday morning.
Just in time for your hot girl walk.
So tune in to But Are You Happy? The podcast where overthinking finally gets the spotlight it deserves. Made in partnership with Medibank.
All right, let's go to our next caller.
Hi, Dr. Pat and Mama Brigid. Long-time listener of the pod. I absolutely love it. And thank you for empowering me in my pregnancy through giving me so much information. I am currently 10 weeks pregnant with my second baby, and my first baby was born preterm by caesarean section because he was breeched. I don't have a reason for why I went into spontaneous labour at 36 and 3, but I am hoping for a VBAC with this second baby. So I'm essentially wondering, prior to meeting with my OB and my medical team, how common it is for someone to have a second breech baby or a second preterm baby. I'm not sure whether there are links between the two, but I just wanted some knowledge to help prepare me for delivery and planning as to whether I need to plan for a baby to come 4 weeks early. Thank you so much for any information you can give on this, and I absolutely love your work.
Great.
Okay.
Now, another interesting issue, and this is an interesting one to me because there some, to a certain degree, these things are predictable a little bit, but there's also it's essentially a whole new roll of the dice, this new pregnancy. So if we look at the issue of the late prematurity, 36 plus, if a woman's got a history of extreme prematurity, say that she had a baby at 27 weeks, then yes, that risk carries forward. There's something about that woman in pregnancy, whatever it is, that puts her at much higher risk of premature labour and birth. But the later, the later in the woman's history, the later the premature birth happened, the more that effect is lost.
Okay. That's good news.
Yeah.
So
it doesn't put her at increased risk of extreme prematurity. She's at slightly increased risk of the sort of prematurity that she had last time, but she might go to full term. Yeah. We don't know why she laboured. She pointed that out. And whilst her risk is a little higher, ultimately, it's a slightly higher risk of an outcome that is not the end of the world, having a baby at 36 weeks. Yeah. the section was needed because the baby was in breech presentation at that time, and there are kind of two things with your risk of breech. Occasionally, there is a maternal reason why the baby is in breech presentation, and that is to do with something like a big lower segment fibroid, where the presenting parts can't sit not neatly in the lower part of the uterus, and you're more likely to be transverse or breech. Obviously, unless that's been fixed between pregnancies, it'll still be there, and the high risk will still be there. Otherwise, if there's no reason anatomically why the baby's in breech, and that just comes down to fetal behaviour. Some babies like to be upside down, some babies like to be the other way around, but it's ultimately up to the baby what position they're in. And that scenario, I would imagine, is just a new roll of the dice when you get pregnant again.
When does a baby sort of settle into their position? Like, when would someone say, oh, your baby is in a breech position?
Well, it's obviously perfectly normal earlier in the pregnancy for the baby to be upside down or sideways or diagonal. That's all fine. There's tons of water, and the baby can kick around. And healthy babies with normal kicky legs love to kick. The whole reason why babies come out head first is there's a lot of kicking room at the top, and not much kicking room at the bottom. So they like to kick, so they put their feet up and their head down. And in nature, some animals where the uterus is a different shape, they will come out
feet first.
Feet first, yeah. So if we look at that issue, for a long time it's just normal behaviour, and I don't get terribly excited about this until about 35 weeks.
Yeah, right. Yeah.
And if the baby's is breeched at 35 weeks or has been persistently breeched all along, then I'll start about that time discussing the pros and cons of the various birth options.
Yeah, yeah.
I would be recommending pretty standard management here, which would be to continue to monitor the fetal presentation at each visit. Hope the head stays down. And then in terms of the prematurity, the risk of extreme prematurity is not high. We would carry on and hope we got a bit longer than last time.
Pat, I did want to talk to you about when you said there's no big drama or something, I can't remember your exact words, if the baby comes at 36 weeks. That is from maybe a medical perspective. Yeah. But like, if you're talking about a person thinking, oh my God, when do I stop work? How do I organise my life? And then all of a sudden that baby comes.
No, I was being flippant there. I think what I meant was there's unlikely to be major impacts on mother or baby from a birth at 36 weeks in terms of long-term outcomes for mother and baby, developmental outcomes for the baby, and so forth. So the later that technical prematurity occurs, the less long-term significance we would attach to that.
Yeah, perfect.
Yeah. I think the call specifically said, I'm trying to plan my life. Well, I'd be planning to have a baby much closer to term by VBAC. Yeah.
Let's go VBAC. All right. I'm going to listen to this caller.
Hi, Dr. Pat and Brigid. I have a quick question regarding IVF pregnancies and birth. I'm currently 18 weeks pregnant with my second bub, and I just had my first midwife appointment. She told me that they generally advise that you are induced at the 39-week mark, and I was planning to give birth at the Family Birthing Centre because I got accepted there, which is very exciting. However, if I am induced, obviously that won't be an option, and I will have to give birth on the normal ward. And I was just wondering if you had any thoughts and opinions or advice when it comes to the recommendation of being induced around the 39-week mark. I know that studies suggest that the likelihood of stillborns with IVF pregnancy are a little bit higher, and it is considered higher risk for multiple other reasons, I guess. And I was just wondering if you had any thoughts on those studies and if they are pretty solid. Thank you so much.
Such a good question.
Yeah, it is, isn't it? I missed it. Did she say how old she was?
No, that's highly relevant because it's important that we try and separate here. When we're talking about risks of a rare but catastrophic outcome, then we need to be really clear on what risk is being added by an IVF pregnancy versus what risk we might have just anyway, just from being pregnant in the first place. So that's why it's a difficult question to answer. and the studies are not good. Let's start with that. They are not good, and there is no randomised control trial. There may never be one. It might be
who would say yes to that? Yeah,
it might be a bit too harsh to say to people, right, we're going to open an envelope, and if you open it and it says keep going, then you keep going, and you have standard obstetric care, which would not be to really interfere for postdates until about 41 weeks, or it might say you're going to be induced at 39. And we might not get a lot of takers for that study. There's a number of potential ethical problems with putting up a randomised control study, but the ones that do get up, it's typically because we honestly don't know the answer, and we can get away with that ethically by saying, well, we just don't know. So that's what the study's for. We're trying to find out. So the data that IVF pregnancies somehow make a poor placenta, that behaves poorly in the third trimester, and brings the risks forward, it is not terribly strong, but there's some semi-persuasive data there. So if it's not an IVF pregnancy and everything else is fine, then we wouldn't really consider that the risks of going post-term would really kick in until about 41. And in my view, round about 41, the risks of keeping on going exceed the risk of induction, the risks posed by induction. And so that would tend to sort of say the pregnancy has been going too long at about 41. Now, there's some evidence that for an IVF pregnancy, that risk is brought forward to term or possibly even to 39 weeks. Now, Colin mentioned it was her second baby. And if she'd had her first baby vaginally, there would be little risk in being induced at 39 weeks anyway. We've got trial evidence that that's a reasonably safe thing to do. And we've got, and we would expect good outcomes, in particular if the first baby was born vaginally. So you might in that situation say, I understand the trial data is poor and hardly completely persuasive, but I don't mind being induced at 39, especially if that can be done pretty gently just by breaking my waters. So in conjunction with the whole treatment team, these things need discussion. In terms of the family birth centre, that's would be a bummer to be kicked out of the family birth centre just because you're being induced for a normal pregnancy at 39 weeks. And I wonder whether that's up for discussion, because we're not talking, in someone who's had a previous vaginal birth, let's say, then we're not talking about 4 doses of Prostin jelly and a balloon and a ton of syntocinon, and we're just talking about someone coming in at 39 weeks and having their waters broken.
Yeah.
For a cervix that, let's say, is ready, favourable, good to go, come in, break the waters, and from that moment on, just wait for labour to come and have the baby.
Yeah.
Yeah. So it would be a bit of a shame if that type of induction disqualified you from family birth centre midwifery care.
Yeah. Look, this is a shame too, because obviously there's a protocol that says any sort of induction,
can't be induced.
you can't be induced, so you need to go into the obstetric ward.
Yep. But there are inductions and then there are inductions.
Yeah.
So, there are some inductions. If you're induced for hypertension, preeclampsia or diabetes at 37 weeks with an unfavourable cervix, that induction might be a terrific idea and absolutely world-class advice. But it's going to come with a 50-50 section rate if it's your first birth.
Yeah.
Yeah. It's just hard to get someone into labour when they're not ready.
Yeah.
By contrast, if you've got someone who's had 3 previous vaginal births and wants to get on with it at about 40 weeks, for no strict medical reason whatsoever, you would still expect that to end well and end in vaginal birth.
Yeah. All right. Good luck. I hope you get the birth of your choice and all made with some really great decision making.
Good luck.
Good luck.
Hit that arvo slump and fighting to refocus? Everything feels harder than it should. I'm Claire Murphy, and this is Well, your weekly wellness reset. No fluff, no fads, no woo-woo, just clear, expert advice to help you bounce back to your best. So whenever you need a second of self-care, join me and our resident GP, Dr. Mariam, for real talk on our bodies, minds, and how to live a healthier life. Listen now, wherever you get your podcasts.
Okay, let's move to this caller.
Hi, Dr. Pat and Brigid. My name is Gwen. I'm calling you from Ireland. I am French, that's why I have an accent. So first of all, thank you for your podcast. It helped me for my first pregnancy, and going into labor, I felt more informed, therefore more prepared to advocate for myself and my baby. I have a couple questions. So the first one is, my baby born head down but facing up. I was wondering if this is something that could potentially happen to me again. Also, is there any way to flip the baby already? Because I was giving a few exercises, but it didn't work for me. I was told that this kind of labor is potentially longer and more painful, so I would like to avoid it next time and flip the baby if I can. The second question is about the return of my period. I'm breastfeeding my daughter, and she's now almost 10 months, but my period haven't come back, and all my mom friends had their period back by now. I'm just a bit worried because I would like a second baby in the future, and I'm worried that my period never come back. I know that every woman is different, but I have PCOS, and I'm wondering if I wouldn't need a little medication for my period to come back. In the past, I had a few times where my period completely stopped and I needed the medication. That's it. Thank you.
How great! Like when she said, "I'm from Ireland and I've got an accent." That's so great.
When I listened to this, I thought, that's it. We've truly gone international. the French people living in Ireland are listening. I love that.
So great.
That is terrific.
So many questions in that caller's question, though, isn't there? Like
yes,
yeah,
yes. So OP birth.
Yes. Sunny side up, is that also called?
Yeah. Looking at the ceiling, face to pubes. It's got lots of
face to
names.
Pubes. Who calls it that?
Vulgar,
that's disgusting.
Isn't it? Yeah. So this is when the baby comes down. If you imagine the woman's lying on her back, baby comes out face up.
Yeah.
And it's a bit of an inefficient position, and it takes a long time during the labour, either for that position to correct itself, so the head turns around to face the floor and comes out the usual way, and that's a 180 that's slow, or baby comes out face up, which is inefficient. They can't really tuck their chin down very well in that position, so a larger diameter of the fetal head is presented to the birth canal, and it's slower and sometimes more traumatic,
a bit more painful.
Yeah. And traumatic to the vaginal skin, vaginal opening, tears, and so forth. So there are two bits of good news here for Gwen when she has her next pregnancy. One is that it just might not happen this time. Right? This baby might have a better sense of direction, come out with a chin tucked in, face towards the floor, and come out no problems. The other piece of good news is that the second vaginal births tend to be a lot more efficient in the first birth. So the tissue around the vagina, around the vulva, has been stretched already, and the labour just runs more efficiently. So that efficient, active phase of labour that kicks in around 4 centimetres progresses quickly. Pushing tends to be better because people are less exhausted when they get to full dilatation. So with everything going in your favour, even if this baby was also OP, the outcomes would be better. Vaginal birth rates would be higher. The baby would be more able to correct its own position. Or if you got to fully dilated in OP position, your birth attendants could help correct that position, which is very hard to do when it's your first time because it's just tight fit. But second and subsequent births, it's possible to turn the baby around.
What is that? You're physically rotating the baby?
Historically, this was done with rotational forceps. In a lot of places in the world, we're moving away from those. They have some risks. But what's something called a manual rotation, where, say, under a good epidural block, we can put our fingers in the vagina, grab the fetal head and turn it around manually.
Yeah.
That's considered a safer, less traumatic way than doing it than with forceps. And it's often doable with a second and subsequent birth, but it doesn't work for first babies. It's too tight.
Yeah. The baby is not moving.
No.
All right, and then moving to the second part of the question, which is breastfeeding in her period hasn't returned, she's got PCOS.
That bit's quite straightforward. Firstly, it's perfectly normal not to menstruate while you're breastfeeding. That's normal physiology. It's nature's contraceptive, and that's perfectly normal. The other women that she's talking to who have had babies around the same time, some of those women, their periods come back, and that's fine. That might be just that woman's pattern. It might be that those women have already started to feed a bit less, breastfeed a bit less.
Yeah, maybe their baby's sleeping through the night, so
exactly. So hormonally things are changing, and it changes enough in favour of bringing ovulation and the period back. For Gwen, that hasn't happened yet, and that of course is normal. Yeah. When somebody has some PCOS and has had a potential issue in the past with regular ovulation and regular menstruation, then the underlying physiological tendency towards PCOS is still there. Right, so she's got pregnant on this occasion. We don't know, but let's say that happened beautifully spontaneously without needing ovulation, induction, IVF, anything. Great. Now we've got another baby. We're going back. We're a little bit older, and we have still got a tendency towards PCOS. So the first thing we've got to do if we want another baby is stop full-time breastfeeding. Unfortunately, so there'll be a time, unless you want to just totally. It depends how old mum is and how big the family size she wants is. But let's say that time has come. Then we've got to stop breastfeeding so much to allow natural return of ovulation and menstruation. And let's say, for example, we've done that and we've completely stopped breastfeeding and baby's now on formula solids, what have you, and the period is still not back, then it depends how much of a hurry we're in. There might be some benefit to waiting. It might just kick back in with time. But let's say we're totally ready to have another baby, we've stopped breastfeeding, it's been months and there's still nothing, then that's just the PCOS.
Yeah.
And that just needs to be managed independently in the usual way with medications of ovulation induction. And we've done some podcasts on this already.
So again, we'll put the links to that. So the PCOS one, the breastfeeding one, we haven't done a stations one, like where the baby is and the difference in the presentations and stuff. So that might be something that we could do too.
Yeah, but it'll come down a little bit to what was necessary to get pregnant in the first place.
Yes.
Say that happened spontaneously just by weight control and time. Fantastic. If it needed ovulation induction last time with letrozole or clomiphene, drugs you take at the start of the cycle to help you ovulate, then it's probably going to need those again.
Yeah, she said she's taken medication in the past, but that wasn't about whether she was getting pregnant or not. Yeah.
Yeah, so if somebody has required ovulation induction to get pregnant once, they'll probably need it to get pregnant again. And when we've had a win with ovulation induction the first time around, we don't usually muck around.
No, we know it works.
Yeah, we know it works, so we just go for it, and do that in a safe way to minimise the risk of multiple births, and off we go.
Yeah. I said we then, as if I've got anything to do with someone's ovulation induction.
You're on the team.
Yeah, good. All right, everyone. That's our last question for this week. I hope you've really enjoyed the questions. They've been really interesting, as they all are. It doesn't matter if you feel like your question is, I don't know, not clever enough or not complex enough or whatever. We want to hear all of them.
No, get in touch. Especially if you're somewhere cool and foreign. Yeah. Then we want to hear from you.
No, we want to hear from anyone from anywhere. But yes, if you've got a question that you think might be just a little bit too easy or a bit simple, you can be guaranteed that there's somebody else with that similar question.
Absolutely.
Yeah, so just ask it. Yep. We love them. All right, so until next week, keep well, everybody. I hope you have a really fabulous week, and we'll be in your ears next week.
Thanks for listening, everybody.
All right, bye for now.
Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.